past Councillor and Vice President, Bangladesh College of Physician and Surgeon, past President, BSA CCPP, past President, SARC Association of Anesthesiologists, and another person chair of this session, Dr. Sunil Wagmari, MBBS, MD, DMRE, MSCP, FIPP, USA, Medical Director, OMSI Super Specialty Hospital Private Limited, Mumbai. Or another person who is the chair of this session, Dr. Jayesh Thakrar, Consultant Interventional Pain and Palliative Care Specialist, Committee Member of Advisory in Narcotic and Palliative Care Program in Government of Gujarati. Now I would like to request Professor ABM Maqsudul Alam sir to conduct the next session.
Hello, it was a hectic day with full of enthusiasm and knowledge sharing. Today we are going to start again. The first speaker will be Gianni Coloni Baldessi. He is had FIPP in 2008. He is the secretary of Italian chapter of our World Institute of Pain. Dr. Coloni Baldessi was certified by the World Institute of Pain as a fellow of international pain practice in 2008. He is a past president of the Italian chapter of International Neuromodulation Society from 2016 to 2019. Now I request Mr. Baldessi to present his paper. Mr. Baldessi, please.
First of all, I would like to thank the organizers and Professor Kabzar Sardar for the kind invitation to the Congress, which certainly required a considerable organizational effort in these difficult times. My talk is about SCS for PVD patients, clinical evidence. Peripheral vascular disease, also known as peripheral arterial disease, is very common worldwide. This condition is extremely stealthy and dangerous for patients. PVD may become life-threatening due to impaired blood flow to the limbs, and this may lead to such extreme tissue decay that the affected area should be or must be amputated. Studies show that within 6 months of initial medical intervention, 35% of critical limb ischemia patients are living post-amputation. Ischemic pain syndromes often do not respond to conventional surgical and pharmacological treatments. Neurostimulation could be effective in pain management. Spinal cord stimulation has been proven from the very beginning as an effective treatment in patients suffering from PVD. Several studies have been conducted in many years. The study of Horsch of 1994 showed that pain relief of greater than 75% in 62% of patients treated with spinal cord stimulation over 3 years. And these results were confirmed by the study by Brozetta and Broggi. The study of Horsch, published in 1994, 177 patients enrolled. The results, a cumulative limb salvage at 4 years was 66%, and a clinical improvement associated with an increased TCPO2. I'm going to show you some paper published in the past years about this topic. And this is a study published in 1995 by Gibagard, 2-center study randomized trial, spinal cord stimulation plus oral analgesia versus oral analgesia alone 41 patients enrolled. Results in this study, amputations, 9 in the SES group, 36%, versus 14 in the control group, 54%. Limb salvage, 62% in the spinal stimulation versus 45% in the control group. Limb salvage not significantly different, though shows a trend to be improved in the spinal cord stimulation group. However, extent of amputations smaller in the spinal cord stimulation group. Ubink and Spinsma published in 1999 the Dutch multicenter randomized control trial. 120 patients enrolled. They divided the patients in 3 categories related to microcirculation with poor, low, and intermediate. And they showed that in patients with intermediate skin microcirculation, amputation frequency was twice as low in patients additionally treated with spinal cord stimulation as in the standard group, 48% versus 24%. In 2003 was published results of the European Peripheral Vascular Disease Outcome Study, SCS-EPOS. 112 patients non-reconstructable with stable critical leg ischemia. And the conclusion was that spinal cord stimulation treatment of non-reconstructable critical leg ischemia provides a significantly better limb survival rate compared with conservative treatment. In this study of 2006, spinal cord stimulation for critical leg ischemia review of effectiveness and optimal patient selection, 444 patients. The study showed that there was a rate, lower amputation rate, 11% after 12 months, compared to those treated with optimum medical treatment in spinal cord stimulation patients. And in addition, spinal cord stimulation patients required significantly fewer analgesics and showed a significant clinical improvement. And in 2007, the study affirmed that in critical limb ischemia patients, the beneficial effects of spinal cord stimulation persist far beyond the first year of treatment, and major amputation becomes infrequent after the second year. This is a study we published on neuromodulation in 2011, spinal cord stimulation predictive parameters of outcome. So the rationale of the study was to try to highlight the existence of predictive parameters. This is to evaluate which patients might be the best candidates to be treated with spinal cord stimulation, and also to reduce the implants or try to reduce the implants in patients who did not meet the minimum standards. We studied 40 patients and we screened transcutaneous oximetry and dynamic capillaroscopy. Transcutaneous oximetry to evaluate the metabolic parameters like TCPO2 and TCPCO2, and the dynamic capillaroscopy to evaluate the dynamic data like erythrocyte blood flow, open capillaries, capillary density, etc. This investigation was made on the big toenail fold, and all patients were affected by chronic critical limb ischemia. Generally, patients switching from Fontaine stage 3 to Fontaine stage 4. These were the inclusion criteria for spinal cord stimulations. patients with PAD, Fontaine-3 4th stage with unreconstructible or failed surgical treatment and unresponder to pharmacological management. Diabetic neuropathy associated with peripheral arterial disease. We studied the metabolic parameters and the dynamic data before and after the implantation of spinal cord stimulation after 1 month. So we studied the metabolic parameters, TCPO2 and TCPCO2, and we studied also the differences between the supine position and the dependent limb and the values of delta TCP2 and the delta TCPCO2 and the change in TCPO2 and TCPCO2 after stimulation. In this slide, you can see the dynamic capillaroscopy parameters where we recorded erythrocyte flow velocity through capillaries, number of capillaries per square milliliter, capillary density, or perfused or open capillaries currently active and their percentage relative to capillary density, percentage of open capillaries. We divided patients in 2 groups related to the values of TCPO2, TCPCO2, and the dynamic data. Group A, 22 patients, and Group B, 18 patients. Obviously, patients in Group B had lower values in metabolic parameters and worse values in dynamic parameters. For more details, you can read the article. Our target, pain decrease, reduce drug intake, increase TCPO2, decrease TCPCO2, increase of open capillary blood flow. These are the values before SCS in Group A, in Group B, related to the metabolic parameters. This after spinal cord stimulation with an increasing values in the 2 groups. Also in the dynamic parameters, we have an improvement before and after spinal cord stimulation in erythrocyte, blood velocity, capillary density, and percentage of open capillaries in the 2 groups, Group A and Group B. 6 months, 1 year. Pain relief in 80% of Group A patients was greater than 75% with no need for additional painkillers. We did also healing of trophic lesions and with a result that the percentage of patients ranking as stage 4 after 12 months in the case of Group A patients fell from 55% to 27%. Further amputation became necessary in 2 patients at 6 months and in other 5 at 12 months. All amputees were in Group B. Given the complexity of microcirculatory activity and considering the results of this study, it is our opinion that the selection of patients should be based on more than one microcirculatory parameter. Generally, TCPO2 has been studied. This Cochrane Database System Review published in 2013 to find the evidence for an improvement on limb salvage, pain relief, and clinical situation using spinal cord stimulation compared to conservative treatment alone. So the authors' conclusion where there is an evidence to favor spinal cord stimulation over standard conservative treatment alone to improve limb salvage and clinical situation in patients with non-reconstructible chronic critical limb ischemia. Significant pain relief occurred in both treatment groups, but was more prominent in the spinal cord stimulation group where the patients required significantly less analgesics. In spinal cord stimulation group, they said significantly more patients reached Fontaine stage 2 than in the conservative group. This study, published in 2013, evaluated the cost effectiveness of spinal cord stimulation therapy in the management of chronic pain, published by Kumar and Ridsby, and they show the superior gain in qualities with spinal cord stimulation versus conservative treatment. 2014, the International Neuromodulation Society published the Neuromodulation Appropriateness Consensus Committee, and here are the evidence level and the degree of recommendation by the US Preventive Services Task Force. NAC recommends spinal cord stimulations as an early intervention in patients with Raynaud syndrome and other painful ischemic vascular disorders. If ischemic symptoms persist despite initial surgical or reasonable medical treatment, spinal cord stimulation should be trialed with the evidence strand 2, 3, and the recommendation strand C. This publication on neuromodulation in 2018, spinal cord stimulation improved the microvascular perfusion insufficiency caused by the critical limb ischemia. 78 patients enrolled, and the author's conclusions were treatment of critical limb ischemia patients with spinal cord stimulation improved patients' walking ability, pain severity, and sleep quality. Spinal cord stimulation should be considered as effective treatment toward limb salvage in critical limb ischemia. In this article published in 2020, 56 patients enrolled. We have a positive clinical outcome after spinal cord stimulation in most patients with critical limb ischemia 1 year after the implant of a spinal cord stimulator. In this publication in 2021, the author said that spinal cord stimulation represents a reconstructible alternative for PVD patients with non-reconstructible critical limb ischemia, and the existing literature provides encouraging clinical results. They should be not neglected. Instead, they should be reappraised in light of the recent advances in neuromodulation with the emergence of new waveforms, new technologies, and neuromodulation targets. Now we have new weapons in our hands to treat this kind of patients to be more effective. And this is another article published in 2021, Improving Limb Salvage for Chronic Limb-Threatening Ischemia with Spinal Cord Stimulation, the retrospective analysis. 29 patients enrolled, underwent spinal cord stimulation implantation and in one vascular center. The minimum follow-up period was 30 months. Limb survival at 1 year follow-up was 97%, and 73% had complete closure of limb ulcers. Pain intensity, skin temperature, and quality of life progressively improved up to 12 months after implant, with Fontaine stage 3 patient improving more substantially than Fontaine 4. Then Fontaine stage 4 patients, as we said before, the best candidate for this kind of treatment, we think, is the patients switching from Fontaine stage 3 to Fontaine stage 4 in the stage of chronic critical limb ischemia. And the author said that spinal cord stimulation is a valid alternative in patients unsuitable for revascularization. And the therapy may be more beneficial in patients classified as Fontaine stage 3. From the articles we have seen, we can say that spinal cord stimulation is a valid therapeutic option. Patient selection is fundamental, and it's also fundamental a multidisciplinary approach. But I think that we have to treat patients suffering from PVD as soon as possible when the patient is unresponder to surgical treatments or unreconstructible and non-responder to pharmacological or conservative medical care. I hope to see you as soon as possible, maybe in the next meeting in person. And I want to thank you all for your attention.
Thank you, Dr. Gianni Colini Baddeshi. Now I would like to invite Dr. Javier D. Andres Aries, FIPP, Unidad del Dolor Hospital, Universitario La Paz, Spain, member of Education Committee, World Institute of Pain. He will talk epidural lysis. Now I would like to request Javier to start his session.
Hello, I'm Javier de Andres. I'm an anesthesiologist. I work full-time on pain treatment in Madrid, Spain. And for me, it's a great pleasure to participate in the second International Conference on Pain and 7th International Conference on Recent Advances in Pain in Dhaka, Bangladesh. Unfortunately, I won't be able to join you because I will be flying to Canada to the Spine Intervention Society meeting in Vancouver. But for me, it's a great pleasure to participate and hope you will enjoy this conference. I would like to thank the organizing committee for my invitation. And I would also like to thank Gabor Rax. I don't know if you know Gabor Rax. Gabor Rax is the doctor who thought about epidural lysis. He described the technique and he has done many papers on this technique. He's my mentor and he's I think one of the best pain doctors in the world. His teaching is excellent and he's one of the trailblazers in the World Institute of Pain. I will go through the following topics. Why epidural lysis of adhesions, a very brief description of the technique, some changes in the technique, criticisms to the technique, and also my personal opinion. So the first problem we've got is taxonomy. You know, when many years ago, when John Bonica first thought about pain, he said the first problem was defining pain, which has been recently redefined. The same thing happens to lysis of adhesions. If you look it up in PubMed, you will see many names: epidural lysis of scars, adhesiolysis, caudal neuroplasty, epidural adhesiolysis, Rax technique, epidural lysis, transforaminal neuroplasty, and epidural neuroplasty. Epidural lysis, well, the indication is based on clinical history and physical exam. There's a catheter thread to the epidural caudal space. Then you perform an epidurogram with dye. You see the dye spread. And if you see there are defects on the dye spread, then and these defects go along with the description of the pain the patient has, then that is your target, and you try to introduce and thread the catheter to this dye defect, and you administer normal saline, hyaluronidase, and some corticosteroids in order to treat this inflammation and to release all these scars. Also, you can use hypertonic saline, but you've got to be very confident you are on the epidural space, because if you are not in the epidural space or you are in the dural sac, then you can have many serious problems. So dye spread interpretation is very important. And the first technique, as described by Gabor Rax, you had to repeat this technique 3 times in 48 hours with the patient in hospital. So why lysis of adhesions? Well, epidural involves breaking down adhesions that are thought to contribute to the pain and delivery of pain-relieving drugs to target sites. The rationale is that nerve roots and the dorsal root ganglion are sensitive to mechanical deformation caused by epidural fibrosis. Patients with an extensive epidural scar that you can see on the epidurogram are more likely to experience recurrent radicular pain. The volume of epidural scars also correlates to clinical symptoms. Surgical approaches to the removal of compressive scar tissue are invasive and costly and do not guarantee success, as there are many regrowth of the scar tissue or irreversible nerve damage. But most patients with failed back surgery syndrome have epidural fibrosis. Most patients with epidural fibrosis will be asymptomatic. This is very, very important. So, fibrosis and the formation of adhesions in the epidural space is a normal response to a surgical intervention and can be found in the majority of patients who have had spine surgery. So, some scars hurt and others do not. So, really, scar tissue is controversial. My opinion, which is great deal of evidence, of course, that scar tissue that fixes or compresses a nerve root or a dorsal root ganglion could be a pain generator, while scar tissue that does not fix or compress a nerve root or a dorsal root ganglion probably won't be a pain generator. But things have changed. We have changed from the 90s, as it was first described, the technique by Dvorak, to nowadays. Rock stars have changed. Even anesthesia residents have really changed, as you can see on your daily practice. So the first change in the technique is the target. For something to hurt, it should be innervated. This is truism. And how is the spine really innervated? Well, there's a very, very good book by Nick Bogdock, Clinical Anatomy of the Lumbar Spine and Sacrum. So they studied where substance P and some histochemical markers appeared in the spine. And they saw that the DRG, is the dorsal root ganglion, is highly innervated. Also, sigmoidophyseal joints are highly innervated, facet joints. Also, the anterior and posterior longitudinal ligament are also highly innervated. And the annulus fibrosus, the intervertebral disc in the outside of it, in the annulus fibrosus, is highly innervated. So we can think of a sympathetic innervation and a somatic innervation. Somatic innervation by the medial ramus and the sinovertebral nerve, and the sympathetic innervation by the white and gray rami communicants. So we can figure out the epidural space as divided, imaginary, into two spaces, the ventral epidural space and the dorsal epidural space, being this division made by the intervertebral foramen. So everything that is before the vertebral foramen or ventral to the intervertebral foramen is the ventral epidural space, and everything that is dorsal is the dorsal epidural space. What is important is that the dorsal epidural space is very poorly innervated, while the ventral epidural space is richly innervated. DRG is there, sinovertebral nerve, posterior longitudinal ligament, and the rami communicantes. So really, the ventral epidural space is our target. Where does it start? Well, it starts mainly where the dural sac starts, where mainly at S2 in the caudal sacrum. So here we've got the dorsal and the ventral epidural space. And here you can see, I don't know if the image is clear to you, epidural interlaminar corticosteroid injection, where all the dyes was going to the dorsal epidural space. Then we threaded a catheter, and the catheter went to the ventral epidural space, which, as you have seen, it's richly innervated and it's our target. So the real target is the ventrolateral epidural space. And this wasn't described in the first papers by Gabor, but nowadays it has been described. Why is it important? Well, this is a very good paper by Chang Hyun, Catheter Tip Position and Effects of Percutaneous Epidural Neuroplasty in Patients with Lumbar Disc Disease during 6 months of follow-up. They demonstrated better outcomes in the ventral group, closer to the dorsal root ganglion and the ventral aspect of the nerve root. And this is very, very important. And also, new targets have been described, the peridural membrane. Here is Wolfgang Rausning, who was invited to the Spanish Pain Society meeting in 2014. He did these fantastic photographs using the Uppsala cryoplanning technique. This is one of the coronal photographs of this dissection. You can see the dorsal root ganglion, epidural fat underneath, also the peridural membrane and the suprapedicular compartment. So the peridural membrane is part of the posterior longitudinal ligament. So the posterior longitudinal ligament can be divided into 3 layers, being the first layer that is close to the periosteum of the vertebral body is the peridural membrane. Then there is the deep posterior longitudinal ligament, then the superficial posterior longitudinal ligament, then there's a venous plexus, the Baxton venous plexus, and then the dura mater. Here you can see a photograph of the peridural membrane. So the peridural membrane is one of our targets for depositing their corticosteroids and other drugs to release the pain and diminish the inflammation. The second change was timing. The first description of the techniques was a 3-day technique, but then a 1-day technique was studied and the results were very similar. They were described by Laxmaya Manchikanti in 2004. So really, he said that the results, the outcomes were similar on a 3-day technique than on a 1-day technique. And also the third change, new procedures have been updated. So sometimes we cannot reach the suprapedicular areas of the peridural membrane. You can imagine with these screws, it is very, very difficult to reach the suprapedicular areas of the peridural membrane. So this new procedure was the transforaminal lysis. Here you can see some pictures of the technique in our hospital. It's a very, very easy. You have to do a transforaminal approach. You thread a catheter. You confirm the catheter is in the ventral epidural space. You can have 3 possibilities, being 2 posterior, 2 lateral, 2 stenotic. Then you do the epidurogram. You watch the dye spread, and then you administer 1,500 international units of Hyalase or 300 units of recombinant Hyalase. In Spain, we don't have, unfortunately, the recombinant Hyalase, and we have to use the bovine Hyalase in 5 ml of normal saline. Then you introduce 0.2 ropivacaine with 12 milligrams of bethamethasone, and you watch the dye spread, and you can see some opening of the foramen with this technique. This was the previous, and this was the post technique. You can see that the foramen is a little bit more wide. And you can see also the dye spread, which is very, very, very important. Then you remove the needle. The fourth change in the technique are the exercises. It's very, very important for our patients to perform some exercises. The rehab post techniques. They are called neurodynamic exercises. They are very, very simple to perform, but really the benefit has not been evidenced. What are the indications for the epidural-lysis? Well, I think for me, the best indication is failed back surgery syndrome, which is one of our greatest problems we have on pain treatment on our pain units. Also on disc disruption, multi-level degenerative arthritis, epidural scarring following infection or meningitis won't completely resolve. Also, pain unresponsive to spinal cord stimulation, but I think this technique should be performed before spinal cord stimulation. Pain unresponsive to spinal opioids and pathologic osteoporotic and traumatic vertebral compression fractures. You can see all these indications in many papers. For transforaminal is when you have pain on L4 or above, you cannot reach the target with a caudal access. There are some Tarlov cysts that are unavoidable, or the absence of sacrococcygeal membrane, which is in 5% of our population. Contraindications to the technique: sepsis, coagulopathy, local infection, the same as in any other interventional pain treatment procedure. Some pre-procedural considerations: it's very important to have informed consent, evaluate coagulopathies, document existing bowel or bladder dysfunction. You must avoid general anesthesia. We all do these techniques under conscious sedation. I think it's very, very important not performing this and avoiding general anesthesia. Preoperative imaging should correlate with patient symptoms, and that's very, very important. Now, all these are the good things. Now let's talk about some little bad things, criticisms to the technique. Criticism may not be agreeable. It fulfills the same function as pain in the human body. It calls attention to an unhealthy state of things. This is a quote by Sir Winston Churchill. So, the first one, dissolution of adhesions has not been validated. The benefits, the absence of epidural filling defects after the technique does not correlate with the level of pain reduction. So, even though you can destroy many of these scar tissue, it has not been correlated that the more you destroy the scars in the epidural space, the less pain the patient will have. It's a pity. The benefit of preventing recurrence through inhibition of fibroblast by hyaluronidase has only been tested with fibroblast, not on neural tissue. The prevention of recurrence through inhibition of fibroblasts with hypertonic sealing 10%, the studies with hypertonic or with normal saline show no difference in normal saline or hypertonic saline. And remember, hypertonic saline can be very dangerous if it's not in the epidural space. If it's in the subdural space or intrathecally, it is very, very, very dangerous. So, another benefit, the breaking down of epidural scar tissue of adhesions. The problem is that biomechanical in vitro studies show scar lysis is unlikely to be performed. And this is a very good study published in Pain Physician 2012. So maybe we're not doing what we thought we were doing. Strong evidence for short and long-term efficacy of percutaneous adhesiolysis, but all the studies have many limitations, heterogeneous comparators in trials. Also, the contrast runoff correlates with better outcomes. The problem is that all the studies that demonstrate this are retrospective studies. There hasn't been really performed a prospective, well-designed study. But really nothing is black or white. So here you can read a very good pro article. Does improvement in epidurography following percutaneous epidural neuroplasty correspond to patient outcome? There's a very good pro article. And here there's a very good con article. Breaking Bad tissue, epidural adhesiolysis, and its outcomes. My opinion, this is my opinion. Epidural lysis is a healing technique for patients with complex spinal pain. The best indication is for patients with failed back surgery syndrome. It needs to be properly performed. Remember the MINT study. The MINT study was a very fantastic study on facetogenic pain, which said radiofrequency of the medial branch was nonsense, was very bad. But the study was not, the technique was not well performed, and the study was not well conducted. Neurodynamic exercises are very important and are mandatory in order to achieve better results. Another important thing is that scar tissue is really controversial, and epidural lysis has not been validated, as many other techniques we perform on a daily practice on pain treatment. So well-designed multi-center studies are needed. Studies should be promoted also without any commercial bias. And to summarize it, epidural lysis, for me, it's the best option for patients with failed back surgery syndrome before having a spinal cord stimulation trial. So I hope you have enjoyed this presentation. Sorry for not being there. And you can write, you can email me for any questions you have. That's my email, which is my name, aol@gmail.com. And thank you very much. Hope you have a very good conference.
Thank you, Dr. Javier de André Aris, for your excellent presentation. Now I am moving to Dr. Sri Pratap Sinha Rana. He will talk on kyphoplasty. Dr. Sri Pratap Sinha Rana, Consultant, Department of Pain Management and Palliative Care, King Hamad University Hospital, Bahrain Oncology Center, Bahrain, Fellow of Interventional Pain Practice, USA, Fellowship in Pain Medicine, Singapore, past Vice President, World Institute of Pain, India Chapter, past Secretary, Indian Society for the Study of Pain. Now I would like to invite Dr. Sri Pratap Sinha Rana for start your session. Thank you.
Good morning, everyone. Today we'll be talking about kyphoplasty procedure. The kyphoplasty procedure is procedure for vertebral collapse fracture. In this particular patients, we have done a D12 kyphoplasty because of the metastatic disease in the spine, which is very painful. When we do this procedure, the procedure is done under local anesthesia. The idea of doing vertebroplasty kyphoplasty is that balloon kyphoplasty addresses both the deformity and pain by stabilizing the fracture and helping to correct the vertebral body deformity. The indication of the procedure is either osteoporotic fractures, painful solitary lesion in the spine, or if there is a wedge collapse of the spine from lumbar to thoracic regions, then this procedure can be done. The entry point for this procedure is the procedure has to be done under local anesthesia or mild sedation. Patient is put in the prone position. The entry point for the procedure kyphoplasty, you can see in the AP view, in a pure anteroposterior view of the spine. When the pedicles are identified, the superior lateral portion of the pedicle is the entry point for this procedure. Similarly, in the lateral view, this is a transpedicular approach. In a few cases, we do the extrapedicular approach, but mostly transpedicular approach is the widely used procedure. The procedure is done the proper painting and draping local anesthesia, 1% lignocaine, it can be given to the patients to numb the skin. And the skin is clean, draped. After cleaning and draping, the anterior-posterior projection is obtained. The pedicles are identified, and once we put a marking, then a small, with the use of 11 gauge blade, a small nick is placed, and from this nick, we can use the 11 gauge biopsy needle into the, it's inserted transpedicularly, advanced in AP as well as in the lateral direction. So mostly you will see here, like we are using anterior and then lateral view of the image intensifier just to see whether our needle is in the right place. The needle should follow a path that is parallel to the superior and inferior edge of the pedicle. Okay. And in fractured vertebral bodies with vertebral end plate depression, a more horizontal directions may be required. Once the needle is there in the vertebral body and it has already crossed the pedicle into the vertebral body, then we can put the guide wire or K-wire to this needle, and gently with screwing movement, the needle is retracted, leaving behind the K-wires or guide wire. And through this guide wire, we insert another trocar. This is inserted. Here you can see with a small gentle tap on the trocar. Once it has reached into the posterior 1/3 of the vertebral body, the stellate is removed along with the guide wires. Important thing here is small gentle pressure is applied whenever you are stroking the trocar. Otherwise, you can have some sort of complications. Okay, so it is always better that with small gentle pressure over the trocar. First, the guide wire is moved here. Once we are 100% confirmed that we are in the vertebral body, almost in the posterior 1/3 and middle 1/3, then you can remove the stellate. Once you remove the stellate, then there is drill which is introduced to make a channel in the vertebral body. So here you can see in the AP view as well as the lateral view, the drill has been inserted into the trocar. The idea is to create a channel in the vertebral body for insertion of the catheter with the deflated balloon. And the exact position we have to again check in the AP and lateral view. Once you are sure that you are at right place into the middle of the vertebral body or at the junction of posterior 1/3 and middle 1/3 junction, then you put the deflated balloon, and size of the balloon is selected on the basis of the vertebral body. Same technique on the contralateral side. Then you inflate the balloon with Omnipac dye, and you can easily visualize in the X-ray that how much volume you are using, and you also need to read the pressure readings. On the balloon assembly. Here you can beautifully see that left side of the balloon is inflated, and later on the right side of the balloon. After checking the positioning by AP and lateral view, the balloon with the continuous control of pressure and volume, basically there is a creation of the radial force that compacts the cancellous bone in the periphery of the vertebral body, leaving behind a void. Then the cement is prepared, and once the consistency of the cement is adequate, then you can insert the cement by using a blunt cannula under low pressure. Possibility of injecting the cement under the low pressure after having created a cave with the balloon together with the restoration of the vertebral height. After injection of cement is completed, the patient is kept prone until the cement completely hardens. Here you can see in the lateral view and in the AP view, good cement. Cement is equally distributed in the vertebral body. So this procedure is all about the kyphoplasty procedure. I have kept the procedure as simple as possible so that to understand the concept behind treating a collapsed vertebral body in cases of osteoporotic spine, in cases of metastatic solitary bone lesion, or in cases of vertebral collapse due to many factors. The difference between the kyphoplasty and vertebroplasty is that in kyphoplasty, the posterior cortex, even if it is breached, even if there is a little bit compression on the spinal structures, you can do the procedure safely. But remember, if there is a marked pressure on the epidural space or near the spinal cord area, then this procedure should not be. So thank you very much for giving me this opportunity to present my case of kyphoplasty, how I do the procedure. Again, thanks Dr. Kausar Sardar and his team. They have done a wonderful job. Thank you very much.
Thank you, Dr. Rana, for presenting such a nice case that we have learned many more things from your video. And thanks to our dear chair, ABM Moxidul Alam sir, for conducting this session. Thank you very much. Now it is time to tea break. Let's have the tea. Thank you again.